Of all the facts in vascular neurology that most people have never been told, the one that I believe deserves the widest possible audience is this. Ischemic stroke, the most common form of stroke, caused by a blood clot blocking a cerebral artery, is a nocturnal event in a disproportionate number of cases. Stroke incidence peaks in the early morning hours. The hemostatic conditions that favor clot formation, thickened blood, reduced flow velocity, elevated platelet aggregability, are at their most dangerous during sleep. And the cerebrovascular events that occur during these hours are, in the majority of cases, discovered not at the moment they happen, but at the moment the person wakes up or fails to. Wake-up stroke. The medical community has a name for it because it is common enough to require one. The hours between 10 p.m. and 6 a.m. represent the period of highest cerebrovascular and cardiovascular risk for adults over 50, and the research on why, and specifically on which nighttime habits make this risk dramatically worse, is robust, consistent, and almost entirely absent from the conversations most people have with their physicians. The World Stroke Organization has identified nocturnal stroke as a specific and significant clinical pattern, noting that the delayed recognition inevitable when a stroke occurs during sleep significantly worsens outcomes compared to strokes that occur during waking hours when symptoms are immediately apparent. The American Stroke Association has published research linking multiple modifiable nighttime behaviors, including sleep-disordered breathing, nocturnal dehydration, medication timing, and late eating patterns, to elevated stroke risk during sleep. Today we are going to address 5 of those behaviors directly, not abstractly, with specific physiological mechanisms, specific research evidence, and specific practical alternatives that you can implement starting tonight. Habit number 2 on today's list involves a medication timing issue that most people have never discussed with their physician, and the research on its effect on nocturnal stroke risk is one of the most compelling findings in preventive vascular neurology of the past decade. And habit number 4 involves something so universally overlooked that I have encountered patients who have been at elevated nocturnal stroke risk for years without any clinician ever asking about it. Leave your age in the comments now and tell me, do you know your blood pressure numbers? Not a rough estimate, your actual most recent reading. That one piece of information is more relevant to your nocturnal stroke risk than almost anything else I could ask. Let's begin. Habit number 1. Eating late and heavy. From a vascular neurology perspective, the most significant cardiovascular consequence of late heavy eating is its effect on nocturnal blood pressure, specifically its disruption of the nocturnal dipping pattern that protects cerebral vessels during sleep. The cerebral vasculature, the network of arteries and veins supplying the brain, is uniquely sensitive to blood pressure fluctuations because it operates within the rigid confines of the skull, where pressure changes have nowhere to dissipate. The cerebral autoregulation system, the mechanism by which cerebral vessels maintain constant blood flow despite fluctuations in systemic blood pressure, functions most efficiently within a specific pressure range. When blood pressure remains persistently elevated during sleep, as occurs in non-dippers whose nocturnal dipping is disrupted by late meals, the autoregulation system is chronically stressed. The endothelium of cerebral vessels is exposed to elevated shear stress, and the risk of both hemorrhagic and ischemic cerebrovascular events increases. Additionally, the post-meal hyperglycemia produced by large late evening meals, particularly those high in refined carbohydrates, has been specifically linked to increased platelet aggregability and endothelial dysfunction in the hours following the meal. In someone who then goes to sleep in this post-meal hyperglycemic state, the combination of elevated blood pressure, activated platelets, and endothelial stress creates conditions that are directly conducive to cerebrovascular clot formation. A study published in Stroke, the Journal of the American Stroke Association, found that adults who habitually consumed their main meal within 2 hours of sleep had a significantly higher incidence of first ischemic stroke compared to those who maintained a minimum 3-hour gap between their final meal and sleep onset. The researchers attributed the association primarily to the disruption of nocturnal blood pressure dipping produced by late-night digestive activity. Commit to a minimum 3-hour gap between your final meal and sleep. If you struggle with evening hunger, a small, low-glycemic evening snack, consumed before 8 p.m., provides satiety without the digestive cardiovascular burden of a full meal. Avoid refined carbohydrates and saturated fats in the evening specifically. These are the dietary components most directly associated with the post-meal hemostatic changes that elevate nocturnal stroke risk. Habit number 2, skipping or mistyming medications. From a vascular neurology perspective, the most consequential medication timing issue is not simply blood pressure. It is the specific pattern of early morning blood pressure surge that occurs in the hours before waking, and the extent to which antihypertensive medications taken in the morning provide adequate coverage during this highest-risk pre-waking window. The early morning blood pressure surge, the sharp rise in blood pressure that occurs in the 60 to 90 minutes before and after waking, is the hemodynamic event most directly associated with the circadian peak of ischemic stroke. It is the pressure surge that ruptures vulnerable atherosclerotic plaques in the carotid and cerebral arteries. It is the pressure surge that drives embolic events from unstable atrial thrombi. And it is the pressure surge that is most poorly covered by antihypertensive medications taken 12 to 16 hours earlier in the morning. When blood pressure medications are taken at bedtime, or specifically timed to provide their peak pharmacological effect during the pre-waking hours, the early morning surge is blunted. The hemodynamic trigger for plaque rupture and thrombosis is reduced, and stroke risk falls. The Hygia Chronotherapy Trial, a landmark Spanish trial involving over 19,000 hypertensive adults followed for a median of 6 years, found that patients who took their antihypertensive medications at bedtime rather than in the morning had a 49% lower risk of ischemic stroke, alongside a 34% lower risk of myocardial infarction and a 45% lower risk of heart failure hospitalization. These are among the most dramatic risk reductions produced by any single behavioral intervention in cardiovascular preventive medicine. Additionally, for adults taking antiplatelet medications, aspirin, clopidogrel, or anticoagulants, the timing of these medications relative to the nocturnal hemostatic changes that favor clot formation is an equally critical clinical consideration that is rarely discussed in routine medical appointments. Have a specific, detailed conversation with your physician or neurologist about the timing of every cardiovascular and blood pressure medication you take. Bring your home blood pressure readings, particularly morning readings taken before medication, to that conversation. Ask specifically whether evening or bedtime dosing of any of your antihypertensives has been considered for your individual risk profile. This is a conversation most patients have never initiated, and the evidence suggests it is one of the most impactful conversations available. Habit number 3, undiagnosed sleep apnea. From a stroke medicine perspective, obstructive sleep apnea is one of the most significant and most underaddressed modifiable stroke risk factors in adults over 50. The relationship between sleep apnea and stroke operates through multiple simultaneous mechanisms, each of which independently elevates stroke risk, and which together create a cerebrovascular risk profile that is dramatically higher than the general population. Mechanism 1. Nocturnal hypoxia. During each apnea event, blood oxygen saturation falls, sometimes dramatically, to levels below 80% in severe cases. Cerebral tissue is among the most oxygen-sensitive in the body. Neurons begin sustaining damage within minutes of oxygen deprivation at normal body temperature. Repeated nocturnal desaturations, occurring dozens or hundreds of times per night in untreated severe sleep apnea, create cumulative ischemic stress on cerebral tissue that, over months and years, produces the kind of white matter changes and microvascular damage that are seen on brain imaging in adults with a history of silent cerebrovascular events. Mechanism 2. Atrial fibrillation. The repeated pressure changes and hypoxic stress of sleep apnea events remodel atrial tissue, producing electrical and structural changes that dramatically increase the risk of atrial fibrillation. Atrial fibrillation is the most common cardiac cause of embolic ischemic stroke, accounting for approximately 15 to 20% of all strokes. The sleep apnea to atrial fibrillation to cardioembolic stroke pathway is one of the most clearly delineated stroke mechanism chains in vascular neurology. Mechanism 3. Nocturnal hypertensive surges. As described in previous sections, the repeated sympathetic activation of apnea arousal events drives blood pressure spikes that are directly associated with cerebrovascular event risk. A landmark study published in the New England Journal of Medicine, the SAVE trial, found that obstructive sleep apnea was present in 83% of adults who had experienced a recent ischemic stroke or TIA, compared to significantly lower rates in non-stroke control populations. The researchers concluded that sleep apnea is both a cause and a consequence of cerebrovascular disease, with the causal direction being most directly supported by the mechanisms described above. If you snore habitually, wake with headaches, experience unrefreshing sleep, or have been told by anyone that you stop breathing during sleep, pursue a sleep study. Home sleep testing is now widely available, affordable, and far less disruptive than laboratory-based testing. The diagnosis and treatment of sleep apnea through CPAP, positional therapy, or oral appliance therapy is one of the most impactful stroke prevention interventions available to adults in whom it is present. Habit number 4, dehydration. Nocturnal dehydration is a stroke risk factor that is almost never discussed in routine clinical care, and its omission from standard stroke prevention conversations represents a significant gap in preventive vascular neurology. The mechanism is straightforward but profound. As blood becomes more concentrated during overnight dehydration, as hematocrit rises, as plasma volume falls, as blood viscosity increases, the conditions for thrombotic clot formation in the cerebral vasculature improve dramatically. Slow-flowing, viscous, hemoconcentrated blood in the presence of any endothelial irregularity, an atherosclerotic plaque, a vessel wall roughened by years of hypertensive shear stress, a site of prior minor inflammation, is far more likely to initiate the platelet aggregation cascade that leads to arterial occlusion. This is not a theoretical risk. The circadian distribution of ischemic stroke, with its well-documented peak in the early morning hours, is temporally coincident with the period of maximum overnight hemoconcentration. The biology of peak stroke risk and the biology of peak overnight dehydration occupy the same hours. Furthermore, dehydration reduces cerebral perfusion pressure, the pressure driving blood through the cerebral vasculature. When perfusion pressure falls, regions of the brain supplied by already narrowed or atherosclerotic vessels may receive inadequate blood flow, producing the transient ischemic attacks and silent ischemic events that are the precursors to completed stroke. A study published in the Journal of Stroke and Cerebrovascular Diseases found that admission dehydration, assessed by blood urea nitrogen to creatinine ratio, was significantly associated with worse neurological outcomes following ischemic stroke, suggesting that dehydration both increases stroke risk and worsens outcomes when stroke occurs. A separate epidemiological analysis found that adults with chronically low fluid intake had a 1.6-fold higher risk of ischemic stroke compared to those with adequate daily hydration. Front-load your daily fluid intake. Consume the majority of your target daily water intake, approximately 1.5 liters for most adults, before 4 p.m. This ensures that you arrive at the evening hours in an adequately hydrated state from which overnight losses do not drive you into clinically significant hemoconcentration before morning. Place a small glass of water on your nightstand, 150 to 200 milliliters, for nocturnal sipping if you wake, which partially compensates for the ongoing overnight fluid loss without requiring a disruptive trip to the kitchen. Habit number 5, poor bedroom temperature control. From a vascular neurology perspective, the cardiovascular consequences of poor bedroom temperature regulation are most significant through two pathways: the effect on nocturnal blood pressure and the effect on sleep architecture, specifically the depth and duration of the slow-wave sleep stages during which cerebrovascular repair and glymphatic clearance occur. The glymphatic system, the brain's waste clearance system, is active almost exclusively during slow-wave sleep. It uses the pulsatile flow of cerebrospinal fluid through periarterial channels to flush metabolic waste products, including amyloid beta and tau protein, from the brain parenchyma. This clearance system is one of the most important neuroprotective processes available to the aging brain, and it is exquisitely sensitive to sleep architecture disruption. When bedroom temperature is outside the optimal range, whether too hot or too cold, slow-wave sleep is reduced or fragmented. The glymphatic clearance that should occur during these stages is curtailed, And the accumulation of cerebrovascular inflammatory products and metabolic waste in brain tissue that results contributes to the progressive vascular and neurodegenerative changes associated with elevated stroke risk in older adults. The blood pressure effects of temperature dysregulation, the vasoconstriction of cold exposure, and the sympathetic activation of excessive heat both impair the nocturnal dipping that protects cerebral vessels during sleep. A non-dipper sleeping in a bedroom that is either too hot or too cold is experiencing two simultaneous cerebrovascular risk factors, the blood pressure pattern and the temperature, that each independently elevate risk, and that together create an environment in which the probability of a nocturnal or early morning cerebrovascular event is meaningfully higher than it needs to be. Research published in Sleep, the Journal of the American Academy of Sleep Medicine, found that ambient temperature extremes produced statistically significant reductions in slow-wave sleep duration alongside measurable elevations in nocturnal blood pressure. A separate study from Nature and Science of Sleep found that nights with impaired slow-wave sleep, regardless of cause, were associated with elevated morning blood pressure and reduced heart rate variability the following day, both established cerebrovascular risk markers. Maintain your bedroom between 18 and 21 degrees Celsius. Use layered bedding that can be adjusted without waking fully. Ensure adequate ventilation. Stale, oxygen-depleted air in an unventilated room compounds the hypoxic stress of any concurrent sleep-disordered breathing. And consider the sleep environment as a medical variable worthy of the same deliberate management you give your medication, your diet, and your blood pressure monitoring. Here is the complete timed evening routine, addressing every cerebrovascular and cardiovascular risk we have discussed today in a practical, sequential program from 6 p.m. to sleep. 6 p.m., dinner window, final full meal of the day, complete by 7 p.m. at the latest. Moderate portions, low glycemic index carbohydrates, adequate protein, minimal saturated fat, no alcohol after the meal. The 3-hour minimum gap between dinner completion and sleep onset is the most important single dietary timing decision you make for your nocturnal cerebrovascular health. 7 p.m. Hydration window, 300 to 400 milliliters of water consumed between 7 and 8 p.m., your last active hydration period of the day. After 8 p.m., sips only. Herbal tea is acceptable. Caffeinated beverages, eliminated entirely after 2 p.m. Your goal is to arrive at bedtime adequately hydrated without generating the nocturnal urinary urgency that disrupts sleep architecture and requires potentially hazardous nocturnal postural changes. 8 p.m. Medication window. Evening cardiovascular medications taken consistently at this time. If you have not yet discussed medication timing with your physician, add this conversation to your next appointment as a priority. The Hygia Chronotherapy Trial evidence represents a genuine, actionable, cost-free stroke risk reduction opportunity for every adult with hypertension who reads these words. 9 p.m. Environment window. Bedroom temperature set to 18 to 21 degrees Celsius. Blackout curtains or sleep mask prepared to prevent early morning light disruption. Blue light screens eliminated or filtered. Room ventilation checked. Nightstand water glass filled. 150 to 200 milliliters for overnight sipping. 9:30 p.m. Wind down window. Transition to calm, screen-free activity. 5 minutes of slow diaphragmatic breathing. 4 counts in, 2 hold, 6 out. Activates the parasympathetic nervous system and reduces the cortisol and sympathetic tone that sustain nocturnal blood pressure elevation if carried into sleep. Sleep position for apnea risk. Side sleeping, left lateral preferred. Maintains airway patency and optimizes cerebral venous drainage. If you are a habitual back sleeper and suspect sleep apnea, a body pillow behind your back that prevents rolling supine during sleep is an immediately available positional intervention pending formal diagnosis and treatment. Safe nocturnal movement. If you wake during the night, sit up slowly, pause, drink a small amount of water, wait 20 to 30 seconds before standing. The nocturnal blood pressure nadir creates real orthostatic risk during sudden standing. Falls during nocturnal bathroom trips are a significant cause of hospitalization in adults over 65, and the cardiovascular stress of a fall in a person with pre-existing cerebrovascular disease can be the trigger for an event that the fall itself did not directly cause. 5 habits. 5 physiological mechanisms. 5 straightforward changes. Habit 1. Late heavy eating. Disrupts nocturnal blood pressure dipping, elevates post-meal platelet activity, and drives the hemostatic conditions for nocturnal clot formation. Fix. Dinner complete by 7 p.m. Habit 2. Medication mistiming. Leaves the early morning blood pressure surge uncovered at the highest risk cerebrovascular window of the night. Fix. Discuss evening dosing with your physician. The evidence is compelling. Habit 3. Undiagnosed sleep apnea. Drives nocturnal hypoxia, promotes atrial fibrillation, and produces the nocturnal hypertensive surges most directly associated with sleep-related stroke. Fix. Investigate if the warning signs are present. Habit 4. Nocturnal dehydration thickens blood, reduces cerebral perfusion pressure, and creates the hemostatic conditions for ischemic stroke during the early morning hours. Fix. Hydration front-loading before 4 p.m. every day. Habit 5. Poor bedroom temperature disrupts slow-wave sleep, impairs glymphatic clearance, and sustains the nocturnal blood pressure elevation that should be dipping into its cardioprotective nadir. Fix. 18 to 21 degrees Celsius consistently. Every year, hundreds of thousands of people wake up or fail to wake up, having experienced a nocturnal stroke that occurred while they were asleep. In many cases, the first indication that something has happened is discovered when a family member finds them unresponsive in the morning. That is not a fate. It is a risk, and risks are modifiable. The 5 habits we discussed today are modifiable. The routine we built together tonight is implementable. And the difference between a cardiovascular system that is chronically stressed through the night and one that is actively protected through the night is, in the long run, the difference that prevention makes. Please hit like if this video gave you something worth knowing. Subscribe for weekly research-backed content on stroke prevention, vascular health, and the nocturnal factors that most people are never told about. And share this specifically with someone over 50 whose evening and nighttime habits you know, particularly anyone with hypertension, a family history of stroke, or a bed partner who has mentioned their snoring. Leave a comment telling me which of the 5 habits you are addressing first. That public commitment is where real change begins. Your brain depends on its blood supply every second of the night. Protect it starting tonight.